Welcome to the Explainer. Today, we're going to unlock the key difference between two types of arthritis you'll see all the time. For you, as a future nurse, knowing how to tell them apart isn't just academic, it's absolutely essential to keeping your patients safe and giving them the right care. So, here's what we're going to cover. We'll start with the big picture, then we'll dig into what's actually causing these two diseases. We'll look at how you can spot the difference at the bedside. Then we'll get into the really important stuff, the medications, and your role as a nurse. And we'll wrap it all up with one big idea you need to take with you into the clinical setting. Okay, so let's just jump right in. When your patient tells you they have arthritis, that's just really chapter one. You see, arthritis is this huge umbrella term. It just means a joint is inflamed and it's breaking down. Both rheumatoid arthritis, or RA, and osteoarthritis, OA, live under that umbrella. But they are two totally different beasts and they require completely different nursing game plans. You can take these super complex diseases and really just boil it down to two simple pathways. So let's get down to the nitty gritty, the core problem. Think of rheumatoid arthritis as an inside job. The body's immune system gets confused and starts attacking the joint's own lining. Osteoarthritis, though, that's a mechanical issue. It's just simple wear and tear. The cartilage breaks down from a lifetime of stress and use. Your job is to figure out which story you're actually hearing. And honestly, it all comes down to this one question. Is the body attacking itself, kind of like an inside job? Or are the joints just breaking down from years of use? The answer to that question changes absolutely everything about how you care for that patient. So, for RA, the key word is systemic. This means it's a whole body problem. The immune system just keeps going after the synovium, the soft tissue in the joints. This creates this nasty inflamed tissue called a pannus, and it literally eats away at the cartilage and the bone. It's a disease of ups and downs, intense flare-ups followed by periods of calm or remission. Now, with OA, the key word is localized. And the story begins with the cartilage. You know, the joint's cushion. It just gets thin from years of moving around. The body tries to fix the damage, but all it manages to do is create these bony little growths called osteophytes. You might have heard of them as bone spurs. So, while you can get a little inflammation, the main problem is mechanical, not the immune system going rogue. So, osteoarthritis is progressive and doesn't typically have exacerbations and remissions like RA. Okay, so how does all that actually look when you're with a patient? Let's talk about the clinical signs you're going to see. This table right here, this is going to be your clinical cheat sheet. You're going to see morning stiffness. This is a classic tale with RA. It's bad. It lasts over 30 minutes, but it actually gets better once they start moving around. With OA, though, it's short, under 30 minutes, and it actually gets worse with activity. You see the difference? And look at the pattern. RA is symmetrical, so both wrists, both knees. OA is often just one side. And since RA is systemic, you get that fatigue, that fever, things you just don't typically see with OA. You're going to see more localized joint pain with OA. Let's look at who this affects the most, and this could give us some clues, okay? RA affects mainly women more often than men. For OA, it becomes more common with age. So interesting, right? So let's talk about meds. Understanding why we choose certain drugs is so important for you as a nurse. It's not just about giving pills for pain, it's about targeting the specific disease. And the goals of treatment, well, they're worlds apart. So for RA, the mission is to suppress that haywire immune system and stop it from wrecking the joints. But for OA, it's much more local. It's about managing pain and inflammation right there at the joint and just keeping it working for as long as we can. So the drugs are totally different for RA. The big guns are called DMARDs, or disease modifying anti rheumatic drugs. Think methotrexate. These actually slow the disease process down. Then you have the biologics, which also target the immune system. Think of these as backup when other medications need help controlling symptoms. Corticosteroids and non-steroidal anti-inflammatory drugs, or NSAIDs, those are just for putting out fires during a flare-up. Then, of course, the important stuff you'll do as a nurse. Now, with those DMARDs for RA, you are the first line of defense. The number one biggest risk for your patient is infection. These drugs tank the immune system. So your patient is a sitting duck. You also have to teach them the signs of infection. In general, DMARDs can also cause GI issues like nausea, vomiting, diarrhea, and stomach pain. Keep an eye out on your lab work, including hepatic, renal, and your CBC, or your complete blood count. DMARDs can cause liver and kidney damage and cause the platelets to be low, so you have to teach the patient how to spot bleeding risk and why they absolutely cannot skip their regular blood testing. So you need to know that some drugs like hydrochloroquine can mess with their vision. Sometimes it's not noticeable at first, so it's super important that they make sure to see the eye doctor regularly. So let's talk about this is where all the knowledge turns into action that keeps your patients safe and improves their lives. It's all about what you do and what you teach. Let's use methotrexate as our example. Your teaching here can literally save a life. Point number one is the absolute most critical thing. Methotrexate is given once a week, not daily. Taking it daily can be fatal. You have to hammer that point home. And because drugs like methotrexate can cause miscarriages or birth defects, you have to stress the importance of why they need effective contraception. For OA, the approach is way more conservative. We start with lifestyle changes, exercise, and losing weight. Those are huge. For pain, maybe we use some acetaminophen or Tylenol or the NSAIDs, and we'll often try a topical cream first to avoid side effects. If the pain gets really bad, we can do a steroid shot right into the joint. And when all else fails, there's always joint replacement surgery. Now, even though the diseases are different, there are some things that you'll do for both. You're always going to be managing pain. You'll teach every single patient how to find that sweet spot between resting and moving. You'll show them tricks to protect their joints, how to use heat or ice, and perhaps the most important, you'll be there for emotional support. Living with chronic pain is tough, and acknowledging that is a powerful, powerful thing. So, after all that, what's the one big idea you need to walk away with? The thing you need to remember when it all comes down to it is there are two pathways. The next time your patient comes in with joint pain, your brain should immediately ask, are we on path one, the autoimmune attack of RA? Or are we on path two, the mechanical issues of wear and tear of OA? So just knowing that you're dealing with one of two totally different problems will guide every single thing you do next. And that's really the heart of it, isn't it? This isn't about passing a test. It's about using what you know to give care that's smart, targeted, and actually makes a real difference in someone's life. So, how is knowing this going to change how you talk to your next patient, how you assess them? Because now, when you walk into that room, you'll have the clarity you need to give them the absolute best care possible.